come out to be non-septic people. That's what we need to understand and keep it in mind, because always as an intensivist we think about only sepsis, but at least 30% of people will come. You are putting time? Yeah. So will be, yeah, I can say it. So that is one thing we should keep. So the definition of septic and septic shock is that even after giving organ dysfunction is dysregulated response. That's all. So in that some patients will go into very severe sickness and others don't go. So in that we know that this is how we have to know the bundles of 1 hour, 3 hours, 6 hours, what we do in every case and what we go about. We know about this. We treat from CTC to ISCCM Hyderabad. Everybody talks about only this and stepwise. But what happens here that when you are going, we know one size does not fit all and every patient is different. That's one point we are going to take home. Nothing else is that actually. So we know about lactate, and lactate clearance is a problem. Lactate, when you have you cannot keep it only sepsis cases will have a lactate. And we all know presently that with all RCTs and the last 2016 guidelines, change of QSOPA, it's not more relevant or only QSOPA. You have to go for MUSE and CIS protocol. You have to think about that and begin resuscitation treatment immediately. That's one thing we should be very much important. From emergency department to ICU, shifting more than 2.4 hours is going to increase the mortality of 1.9%. So the capital refill time, and if you look at it, what I am trying to say here is that accessibility of lactate for every patient and point of care in ICU in every patient is available, every person is available, not available, maybe available in the city of Hyderabad, not in all ICUs in every state or every city. So that's the reason you should keep it in mind. And when you're looking at it is we think that we give a fluid resuscitation and antibiotic within 1 hour and start. But at the same time, we are looking at the outcomes measure. In spite of giving the best efforts and best intensivists, and still it has come down from 60% to 40% of outcomes. At the same time, when you look at the capillary refill time, and particularly our complexion of color, it's not very easy. Maybe like Vargo can be easy to identify, but others it's not easy to do that. So, and applicability of CRITIC is going to be issued in particularly South African countries that have been studied in Zambia also, and looked into the studies. So, as physician, I would like to say one thing, that the tropical diseases need to be excluded. Because if you see last COVID phase 1, phase 2 and phase 3, at that time whenever a patient comes with this one, definitely we used to give H1N1 also as suspected, then think about giving a doxy and as well as fluid. This was immediately we used to give to the patients. So because you have to be having a time and duration, because outcome is going to be depends on how early you are going to treat. 30 ml per kg crystallite, everyone knows about it, how fast, how early, whether you go for fluid resuscitation, doesn't matter whatever you give normal saline, you give a regular lactate, it is not going to affect, because 42 liters of body fluid is there, in that 3 liters doesn't matter, and 2 liters up to that. But at the same time, we have a lot of debate on which fluid to be given, whether you want to give albumin or not giving and what percentage. These are going to be debatable. And we all know about dynamic indices. Nowadays, everybody is using ultrasound. It is an extended stethoscope, not just looking at the collapsibility of IVC and just you have to go for the vexus, that's venous. Whether you are having the IVC collapsibility, looking at the hepatic vein and renal veins, and whether it's going to be, because that's important area. What we remember is a CVC, there's a central venous line, in that you have a venous pressure of more than 8 of CVP, will have a lymphatic drainage is going to stop. That is going to increase the outcome based on the patient's of fluid accumulation, which is not going to be into the intracellular space. That is the reason we should keep, and nowadays thinking about vexes. So admission to ICU, as I told you, it's whoever is shifted from emergency department to the ICU. If you are having a post-emergency department place and having it protocolized, even though started around 15 years back, reverse et al. Early good diet therapy, and looking at all the promised trials where they have given more than 8 liters of fluid for all the patients which started, that is being still validated, but for a particular patients. One thing which doesn't have any place anywhere, whether you have ultrasound, doesn't have some map. Map is one thing, more than 65 is going to be standardized. There is no debate on that. So if you look at it at the same time, the probable need, some patients like particularly having a renal failure or having a cardiac failure, congestive cardiac failure or post-MI, including the sepsis, they need less fluid, because fluid is going to kill. Because fluid is a killer or saver. If you see properly, if you give it a right time, because even in the initiation of fluid you start, at the same time understanding, previously around 10 years back when you used to give, you just give the fluid, you hear the rails. That was a topic at the time, but it's not so. Even the patients, even in sepsis, if the patient is having a ejection fraction of less than 25-30, is having a post-cardiac, people nowadays coming with the PPS, PPIs, those people cannot be given. We have to maintain the patients with the ultrasound management, and that's what we look at. Because just going for a single 30 ml per kg doesn't suit, and they can kill the patients. So that is what I say, that every patient has to be taken. And dynamic indices, we all know that when you are using the ultrasound dynamic, where your collapsibility, and we have the limitation of doing a leg raising test of how much, because 500 ml to 1500 ml of fluid is being going to the central, and not only just looking at the bedside of heart rate and the blood pressure, and how much pulse variability and stroke volume variability you are going to see the patient in the lines, and that will decide as that how you are going to manage the patient. So, if you see that the resuscitation, whenever we have a capillary filtrate resuscitation, that is not easy, because it's easy for pediatrics. We have been learning in the pediatric ICUs and pediatric neonatal time how easy it's going to make a difference of it, but in adults it's not easy. But there's one very easy way of doing a cost effectiveness of the patient monitoring at the bedside. And even if you can able to adapt properly ICU protocols, and survival sepsis guidelines has been read, adjusted, remembered, and trained by all the duty doctors on the night time, because in ICU, in emergency and ER, whenever they come, the highest qualified person is in the ICU, and the just whoever, I'm not degrading anybody, whoever is not got a PG seat and just waiting, working in emergency department is going to attend the critical patient in ER. That is what is going to be different, because the time is going to be, time is muscle, time is brain, time is life in sepsis. That's the reason the quality and the qualification of the person staying in the ICU is different from in ER. That is the reason the time duration in the ICU is important for making the decisions outcomes. So, the map is one of the important things where we know that in hypertensive patients maintain a map of more than 75 up to 65 has been given, but in the long-term meta-analysis it has not shown any benefit, because if you see the cerebral perfusion pressure and renal perfusion pressure, there is a long variation compared to the other organs. So other organs cannot maintain. So that's the reason that maintaining of at least even low perfusion pressures of shock patients sometimes can be outcome is no difference if you give a proper antibiotics and resuscitation over a period of 6 hours to 24 hours. But at the same time, the time is a crux. So the continuous re-evaluation such alternative diagnosis, we know from ACLS to the ATLS to the sepsis, everywhere re-evaluation, looking at the cause, looking at the reason, and understanding the patient condition, and diagnosing again whether we are doing it properly and substituting. Because any patient, when you see, we look at a patient looking at the same, not just by the blood pressure, we look at 4 things. We look at physics and physiology by vitals, and the radiological, and as well as what we look at the lab. These 4 things will mix together and say the patient's clinical outcome or communication. That's one of the important things when we look at the patients. Whenever you see the patients, most of the doctors, I don't disrespect any other concern. When he comes and he says that the patient is fine, no, why don't you extubate him and try him? That's how people say. We have all the indicators, we have a guidelines for weaning, not just like the post-anesthesia care. In ICU, it's going to be different, whether you go for NIV, whether you go for removing the patient from the ventilator slowly, whether you go for the indirect NIV. So, when you look at the empiric antimicrobials, everybody knows about antimicrobials, and nowadays everybody is turning towards the nutrition compared to antibiotics. But the antibiotics, if they have meningitis, you give a high antibiotics of meropenem or torbacillin, whatever you want to use, not going to cross a blood-brain barrier and subtraction 2 grams is going to save the patient, not any of the higher antibiotic. Doctor coming giving in higher antibiotics. The correct antibiotics at the time of 1 hour is important, not the higher antibiotics. So whenever you are giving, it is strongly suspected. We know actually practically the antibiotic resistance is not coming by our ICUs. It's a fact. It is coming by the usage of higher antibiotics in animals and the poultries and the fishes. That is where higher antibiotics is used. Whenever in other countries of Switzerland and other places, how do they assess the resistance? They check the soil of antibiotic, what antibiotic levels in the soil is there. With that feces and antibiotic level, they look at the antibiotics. Last month I was in ECMO training in Abu Dhabi, and there in Cleveland, only first dose of antibiotic any consultant can do. Second dose he doesn't have right to write. He cannot write. So that strictness can we follow? In the ICUs, I don't respect anybody or disrespect anybody. In small villages, I have antibiotics given by everybody. That is where we are going to have the problem. So approach to the antibiotics and maintainability. These are some things which doesn't matter. First you start with doxycycline, and when you look at, think about other things, because history is going to be one of the important aspects whenever you treat the patient, because even first 1 hour you treat the patient of shock, at the same time come back, spend 15 minutes of time. Because 1 rupee spending for infection control saves 1000 rupees for antibiotics. Same way, 1 minute of spending with the relatives properly with the history will save a lot of diagnosis, will come 50% of it. So the other thing is that whenever we have empiric antibiotics, should therefore we cover tropical infections also, because not world cause much harm unless you have a lot of clearance is not there, GFR is low. So keep it in mind, and identification source is important. We know that first, as soon as first, the third step is going to be identification of source and removal of infection from the source. And keep it in mind in the tropical areas where we have, think about the malaria and dengue also, because don't keep the aware from mind is only sepsis, because most of times post-operative we keep only in mind and the sepsis, not other things. So 4% of the Indian population at this point of time getting a fungal infection as well, because the people who have been admitted more than 90 days before, or he was in other hospital or nursing homes, he was a chronic kidney disease, the dialysis, those kind of patients are having a fungal infection. We will not have a thinking in the first beginning of empiric antifungals, because whether you give antifungals at the beginning, no, you don't need to, because that's where the history and other things comes. After 72 hours of antibiotics patient is not improving, then you think about it. Otherwise, wait for 1 week to 2 weeks, then only think about it. The second spike is coming to the hypotension and the shock or sepsis, then you think about antifungals. So, procalcitonin. When we see that from the beginning, we used to read about procalcitonin, early procalcitonin. Nowadays, it's coming from the within 1 hour. Even for antimicrobials, whenever we are using, and at the time now we have a biofire, within 3 hours you get all the mic levels and as well as what you have. Maybe it's not other places everywhere, it's not available, but it is available presently with the, not the point of care of within immediately, but within 1 to 2 hours you can get what type of organism is growing. So PCT is not at all identified or thought that it is going to start antibiotic. It is for the stopping of antibiotic or how the patient is responding. And never always, when 20 years back I used to start with peripheral smear, that used to give me a lot of insight. What is the band forms? What is the size of the cells in the peripheral smear? You have a deviation, left deviation, and what is how much is there? That is to give me clear picture along with the going with the CRP. Even with procalcitonin, it is not only supportive, it is not going to be confirmative. And if I look at it, the use should be tempered and linezolid should be tempered, because whenever you are looking at the combination therapies may be useful, because when you have a gram-negative continuously for more than, if it is high risk, if you suspected, then you go for a double therapy. And always the guidelines for the use of procalcitonin ratio usage, that is what our Indian ISCCM people have been studied very well and published. Hemodynamic management, we all know about hemodynamic management. What is it? Starting with the crystalloid at first choice. In 2004, there was a safe study from John Mayberg in Cobra Hospital in St. George, and at that place where we studied and we looked into that, saying that 4% albumin with versus other things. It is useful, but not in the beginning, because capillary leak syndrome is already happening, since it is happening, even if it is not going to stay back, because the fluid, intravascular management of staying the fluid, what time is important depends on the content of the fluid. That is the reason that even now, first 3 liters or first 30 ml is not useful to think about. But later on, looking at the quality and the kidney function, the heart function, then thinking about albumin. That's what is important here. Anyway, we should avoid starches. I think if anesthesia is done, they all studied what are the complications, we should not be using it. Then we keep that renal lactate is the best cost effective for our Indian setup, or whatever we call it as. And hypomalemia is more common in India, and particularly for more of vegetarians as well as the patients in having old people, those kind of people where the muscle mass is not much, and those kind of people will have, and the CKD people will have hypomalemia. One of the critical indicators of the hypoalbuminemia is that mortality outcome is being even understood in ICU, that whoever is having less than 2.5 albumin, the mortality is high. Not only that, in ICU, even the delirium happens once, there is a 10% mortality within 1 year. Subtle small things knowing about brain biomarkers in the ICU coming without any GCS low, after 6 months mortality is 50%. So that is how we have been understood presently. With these things we can know that what is going to be important in ICU. Then it should be created and understood that you should not use the gelatin for starches, because it's going to be more harmful, the mortality is going to be higher. So we all know everyone comes from beginning, we used to start with the dopamine. In the sepsis guidelines, even they say that particularly countries like some countries, they don't have a non-imperative, still they start with dopamine. We know it is not going to be correct, it is not correct, but at the same time we should reiterate and tell them that it is having a dysregulated response. That is the reason go for the non-epinephrine. If it is cost, you think about epinephrine. The heart rate is the only issue, otherwise most of the things both work together in a better way. So we know that the vasopressin, when they used and they studied together, in the long-term meta-analysis, there was no difference in the mortality or ventilator-free days or the 90-day mortality. So whether you start with, whenever you start with, we give IV fluids as well as simultaneously not to delay within 4 hours. Because you start with the fluids, then immediately within 1 to 2 hours, non-equally grow with the electrodes, then again add within the next 1 hour you have to see. Because just like a ventilator putting on MIV, after every half an hour you have to watch the patient. Here also in sepsis patient you cannot write and go. When you receive the patient in sepsis, whether you are received after 3 days or today, first 6 hours you should be there every hour with the patient to analyze all these 3 things. Then only you will get a good outcome. And some countries still they are using, better not to use at the same time. Epinephrine may be economical and invasive arterial. We know that even blood sugar, when we are checking in peripheral and shock patients, the sugar is not correct. The central blood pressure and the peripheral blood pressure, central blood sugars and peripheral blood pressure, the perfusion is not there. It is not regulatory. Even the gravity, 1 feet is going to be different with 2 to 5 mm, which is difference of blood pressure there. Intra-arterial also major and minor. If you look at the radial and the upper body, the surface area, and as well as the perfusion of this one, there will be 20 mm difference will be there. Better to go for femoral arterial line. That is having better idea of giving the patient because mobilization procedure as well as easiness for a further. So, and at the same time, even now, there was no much difference of outcomes if you do inotropes up to 0.25 micrograms per kg above the elbow. Below the elbow, not correct, but above the elbow, having the lines anywhere with extranuclear still have saving because first 6 hours you are going to see the patient and analyze, and you can come down on it. And it should be even now sparingly used because not easy. Every issue is not having arterial lines. And peripheral axis need to be emphasized properly and look at the maintaining correct fluid balance chart has to be emphasized because you see the accumulation of fluid after few days. Whether you know ROIC protocol of Rose protocol of fluids, whether you are going to resuscitate and stop and again evacuate. This is what we have come to research. So under that there is no maintenance of fluids. Once the resuscitation is done, it's important. Intravascular is maintained fine. Then it goes to the leaky syndrome that's dangerous. Keep it in mind. So everyone have a lot of debate from the beginning about this one. What is going to be steroid used or not used because there is an external steroid and internal steroid. When you are using external or internal, in the patient having himself is always physiological. So having that to start with vasopressin in the beginning is okay, but later on avoiding and being off is more important. And even 200 mg of hydrocortisone in divided doses has been given much benefit. Everybody is using, but not to start early. At the same time, early weaning of steroid is very important because every day within 3 days or 4 days better because when we looked at 190 days of mortality afterwards, there was no difference of using hydrocortisone, nitrocortisone. It's been said in 2021 guidelines as well. You can go through the steroid level page, what is being clearly that it is not going to be beneficial for all the patients. The total outcome is no difference. So think that only at that time of requirement because your supplementing is required. I'll just complete under 1 minute, Rachel. Thanks. So finally, the extra control, everyone is thinking about extra ECMO and every patient, and that is one of the easy way of getting it. Okay, we can do one cost to the corporate hospitals and also the name and feel for the people, but at the same time, indications have been given clearly. There, here, when you do, and at the same time, filters nowadays because it's come from different companies have come. It is not shown a benefit for the patients of outcomes because it is only certain patients of age less than 40 years of age and early and having a clear-cut filter size that has been decided said that is going to be beneficial, but not all the patients. So, immunoglobulins, it is particularly for only a first time of a disease of 24 hours and it's not continuous and never think about overusage has been come into the last 10 days, 10 years, that should come down. Please reduce the ulcer prophylaxis because it increases the Clostridium difficile and increase the trauma prophylaxis treatment because the awareness still is not happening, that is going to be dangerous. So, use of partnership for everybody should not be there. and you should not be using for all the patients because there's clear guidelines are there that 48 hours of ventilation, having a coagulation profile abnormality, and having the patients are reality. Renal replacement therapy may not be required for everybody because the different of hypotension you do CRITIC, otherwise you do external dialysis. Those kind of patients starting early because unless refractory hyperkalemia, refractory acidosis, and refractory only the thing which is required, otherwise not to start early because some depends. I have 3 nephrologists, one nephrologist doesn't start, one nephrologist start within 6 months, depend 6 hours whenever there is urine output is. Because unless urine output more than 12 tolerance is not there, should not be started early unless you give the good trial has been given. So this is we know about the therapy of nice sugar study of 140 to 180. And vitamin C has been anti-inflammatory, worked well this anti-community. So well, but at the same time not to be given for all, it has not shown benefit including the thiamine added because it is not shown benefit of total outcomes of mortality. That's clearly said in 2021 guidelines saying that because most of them in COVID time everybody used it right and left. So because every one patient of diabetic in world from India, so every 4th patient. So that is why the number of diabetics are very high. They may not be knowing de novo patients may be there at the time. Whenever the patient comes to us, better I go for one HbA1c in the beginning, then go for this. And then we know whether to start early insulin or wait for another 2 doses of more than 200. So better not use bicarbonate for patients. We know the clear indications of when to use, when not to use. And we all know that first 78 hours, whether give nutrition, don't give nutrition for shock patient, nothing will happen. After that only we have to think about it. Because early enteral nutrition is best. Reaching 80% of nutrition status of calories, combination and protein. Protein also comes up to 2 grams today for older patients who is having a sarcopenia, obesity and having less muscle mass is beneficial. That will improve the, I don't say outcome, but mobility will definitely benefit. So in summary, sepsis remains clinical, diagnostic and therapeutic challenge for every one of us. At the same time, I would like to say that it is not one size doesn't fit all is the only point. Every patient should be looked into all this aspect of, we have, even though 93 points are relevant, there are at least 16 points which the first 1 hour, 3 hours, 6 hours bundles have been taken care properly. Then the outcome which was 40% will become 100%, 60% will become. That's all depends on our empathetic, our approach towards the patient with the continuity of compassionate care. Thank you very much. That will not come this. Anything to add? Please, Babu.
Any questions from the audience regarding shock and refractory shock? All of you must be seeing a lot of patients with shocks where you can't revive or resuscitate the patient.
Particularly, just one second. Particularly when it comes to the ER, we go with the rush protocol of refractory shock and identify these 4 things of cardiogenic and then that's one way we go. But when you go to the sepsis guidelines, we go for this. Go ahead.
It's not a question. I want to begin from the analysis. Like we put a carpet view when a patient with known neglected sepsis and comes to us, it's a visual shock or a visual analytic shock. But there lies a component of sepsis-induced myocarditis or cardiogenic added component, predominantly vasodilatatory, but partly cardiogenic, partly hypovolemic, because in sepsis again the volume assessment itself, there are so many limitations out there. So many times only vasopressors, not iron pressure, vasopressor will keep on increasing, that's how we are trained. But we forgot to look the cardiogenic part because the sepsis, how much of the cardiac component attribute to the shock? How much of the volume component attribute to the shock? Because unlike a bleeding patient or a vomiting diarrhea patient, we think it is a volume loss. There it's because of the increased volume, increased the capacitance and the remaining same volume. Probably we fail to calculate the volume deficit component. Like, is there a way out to find out to delineate? Okay, probably there is majority of the vasodilatatory, some part is cardiogenic, some part is hypovolemic. So that will give some better idea to approach the shock.
You are asking very difficult question.
Yeah. See, normally when the patient comes to ER, as intensivist, if the ER person calls you, we go for a rush protocol immediately. When we go there, whether within few hours, whether it's a cardiogenic or non-cardiogenic we are going to see, and there is no RWMI, you go for VTI. When you look for the VTI in the echo, then in that the difference between within 12 hours to 24 hours, how much is going to be? Because even the myocarditis can be there not only for the sepsis cases, even non-septic cases, other diseases also can happen. So, if it is MI or cardiac disease, it is immediate. And if you are giving it the fluid as having this one, we know the stroke volume difference of cardiac output difference. There you will come to know what is going to be, how fast it is going to degrade. Whether vasodilatory, that is the reason there we start early inotropes, not the fluid resuscitation. If the fluid resuscitation is giving more damaging, that is where we go with the Vexus and VTI and go with the inotropes first. Then the fluid resuscitation becomes slow because the nephrologist will come and say that you need to go only 800 ml per day or 1000 ml, not more than that. Cardiologist will say that only 25 ml per day, not more than that. You are not bothered about other things because it's focused on that organ. As an intensivist, our job is to look into these three things. These three things will happen. One is whether you give the fluid for resuscitation, we all know having a PLR, and we look at the IVC collapsibility, we will look at the mixes of organs, whether we can give the fluid or not. That is where the start. And early, as I said, biofire within 2 to 3 hours you will get it. You know exactly whether it is sepsis, non-septic. Anyway, you give this masala of thinking about suspicion, you will send the fever panel and go for the VTI. If the VTI is changing within 2 to 3 hours, that's what I discussed with the cardiologist. That means it can be of cardiac. Otherwise, it doesn't have such a fast result because sepsis will take few hours of this one unless he has come to the margin line. That is what my clinical experience is. The rest of these I leave it to you.
I will put it the way we should approach such cases. Myocardial dysfunction in sepsis, it could actually not be that patient that is worsening the outcome. Like you don't treat a pH of 7.25 just with artificially with bicarb. That's because the patient is acidotic. So that's a partial decompensation of the body and partial compensation of the body, and the patient or the body can actually continue to work with a little disadvantage but adequate levels of even within 7.2 pH, and we don't arbitrarily correct to 7.35. Similar happens with myocarditis or cardiac decompensation. We know sepsis causes cardiomyopathy. It causes end diastolic volume increase, which is basically relaxation of the left atrium, and that relaxation of the left atrium ultimately increases the end diastolic volume, which leads to better cardiac output, better stroke volume, and better cardiac output. Along with the tachycardia, the left ventricular stroke volume improves, which improves the cardiac output, which is the basis of treatment or the patient's own compensatory mechanism to improve the blood pressure. So that is actually myocarditis, it's cardiomyopathy, not myocarditis. The terms are actually, once we talk about carditis, we mean inflammation. So it's actually not inflammation, it's just a cardiomyopathy. The muscles are showing little relaxation. They are not absolutely contracting the way or the more relaxed you will stay. So that's a compensatory state. But when you come to a state where you see the patient has significant elevated dysfunction, even a patient not having a prior coronary artery disease, a young guy, 40-year-old male who doesn't have any comorbidities, develops significant, now the word significant we don't know, it's 40%, 30%, 50%, no study addresses that. But what we know is that if there's significant elevated dysfunction you see, excessive tachycardia, inappropriate sinus tachycardia, that is when cardiac decompensation is starting. You get, and atrial fibrillation actually is the end point of it. If a patient with septic shock starts to have atrial fibrillation, that is actually where the cardiac decompensation has started. And there most of the patients will have negative or bad outcomes. So excessive tachycardia can be used. We use a goal of 140 to 160. Anything more than 160 is very detrimental for the patient. 140 below is acceptable in a septic shock scenario. 140 to 160 is more of a clinical decision based on the bedside doctor who is deciding. So cardiac decompensation does happen in sepsis, but most of the time it's compensatory state. And refractory shock, one of the causes of it is basically cardiac decompensation. Another thing which I want to tell, this is where how we approach a patient. If you see LV dysfunction on the echo, and the patient is not volume responsive, and the patient has excessive inappropriate or excessive tachycardia, probably that is where the cardiac element is significant. And in such cases, maybe slight reduction of the heart rate with a smaller trial which they have done. I mean, they are targeted heart rate of 95. I don't know why they targeted 95. That's a too low a target. Sepsis maybe would actually accept a heart rate of 120 quite okay. Especially young guys who would like the heart rate to be 90. So Little bit of targeting heart rate lesser than that 150, 160 levels may be beneficial to improve the cardiac performance in such conditions. And maybe correction of acidosis may help at that time. That is one area I feel cardiac acidosis by correction of. You may institute a CRT in the patient if you want to clear lactate. That's the only thing which can clear lactate quickly for 6 hours. Maybe that may help. So we do. These are all realms we don't know. Second part I want to tell you about the concept of refractory shock is again a very difficult scenario with no clear definition exists in the scientific community of what is exactly refractory shock. But loosely defined as 0.5 microgram per kg per minute of noradrenaline or more is loosely defined with evidence of organ dysfunction. And the major reason which I want the students to understand the refractory septic shock is a situation where noradrenaline responsiveness is not coming. Probably because of down regulation of the receptors. You have given noradrenaline for 24 to 48 hours, the receptor saturated. Or we never think of this part of the story. Why does vasopressin work along with noradrenaline better? Because probably there is this significant down regulation of the receptors. Receptor saturated, you keep on increasing noradrenaline, there is no receptor to take noradrenaline. So obviously that's when vasopressin does start to work. And so early use of vasopressin may be one way actually preventing or improving a patient from going into a refractory septic shock. Obviously when the patient going to refractory shock, you may require 3 or more vasopressin. 3 vasopressin the minimum you require vasopressin. And use of dopamine is strongly discouraged for the students. If you want to use dopamine, the equivalent is adrenaline. So adrenaline achieves whatever dopamine does in a much better way. And the concept that adrenaline, some people come and tell me adrenaline causes lactate rise. It's very clearly mentioned adrenaline only causes aerobic lactate rise, not anaerobic lactate rise. So aerobic lactates are never a worry for us. It's anaerobic lactate. And any dose of vasopressor you use, higher doses will ultimately lead to tissue hyperperfusion, whether talk of NORAD, vasopressin or adrenaline. Once you cross a particular threshold, there will be severe vasospasm and secondary effects. So that limiting factor should be there. Not that the what drug to use. Should not use adrenaline because it may cause spasmodic ischemia or it may cause increased lactate. The increased lactate most of them is aerobic lactate. These are a few points I want to tell you. So yes, you have to look at those parameters to know whether you need to work on the cardiac part. And ECMO is the one thing which I think in the future for these patients, where there is a doubt of refractory shock and the patient has significant cardiac element. ECMO probably this is the ideal patient who is going for ECMO.
Because as you said, supportive measure, because still recovery happens, is going to be helpful, not for them. And the second point, as you said rightly, is that heart rate for freshers. See, heart rate crossing more than 120 will not have a proper coronary filling, that can cause MI because less time of diastolic time, so that there is no coronary filling.
There was some persistent aortic dysfunction, so just converted to a peripheral VA ECMO. Post of day 1, there were bilateral infiltrates. You can see on the left extreme right there. Oxygenation was actually pretty okay. We cannot grade PGD because of being on ECMO, but otherwise the PA was acceptable. Bronchoscopy showed normal anastomosis. But at 72 hours, we noticed that the infiltrates worsened with right-sided infiltrates being significantly worse compared to the left side. So there was a doubt as to whether because it was a bilobar with the middle lobe in. So there was a doubt as to whether there's a vein stenosis and infarction, venous infarction. So we quickly got to CT as well as echocardiography. It was able to cut this thing that the veins are okay, not an infarction. What the CT did show was that there was a hematoma with the residual space collection. So this is acute cellular rejection. So you can see another example of rejection which will show you in the next slide, and very briefly I'll talk about the infection. So this is a patient who is 3.5 years post-transplant. Was done for cystic fibrosis. This is he had significant gastroparesis post-transplant, but that was asymptomatic, so we managed with prokinetics. He developed worsening gastroparesis around the 3rd year, and he presented with increasing dyspnea. You can see the serial single antigen beats on the right hand side. All the initial single antigen beats are completely negative, if you can notice. And then from the time around the presentation, you can notice new antibodies have actually appeared. These antibodies are actually against the donor lung. So gastroparesis is the risk factor for acute rejection and chronic